Appreciate it. All right. So let me know if you guys can see my screen. Can you guys see my screen?
Got it. Yep.
All right. So thanks, guys. As Greg was mentioning, it's an absolute pleasure to share my experience with you guys here this morning. I am tremendously passionate about both spinal oncology and spinal deformity, and I'll even show you near the end of this talk where both of those things intertwine. I'm going to focus primarily on the management of primary spine tumors. I think that management of that is a little bit more controversial today than ever, as it should be. And hopefully I'll give you guys a little bit of food for thought. So the objectives of this talk, I'm going to introduce to you guys how critical it is to use modern 3D printing technology, not just to plan the surgeries, but to execute the surgeries. And then we're going to talk about a novel classification system that I am hopeful will help us not only teach these surgeries, but study these surgeries so that we can maybe one day come to a consensus as to when it makes sense or not to offer these surgeries to patients. So let's get started with 3D printing. So 3D printing can be used, of course, to make patient-specific implants, as in this case here, which was the very first one that I did to reconstruct a patient's pelvis and lumbar spine in the setting of a horrible Charcot pathology. And it's what led me down this path to consider this for the primary spine tumor patients. We published on this, and if you're interested, you can find this publication. It details exactly what you need to do for an IDE perspective to talk to the FDA and have these patient-specific implants approved for each individual single use. But perhaps even more importantly is the use of preoperative 3D models of every single primary spine tumor that I did. This is a scattering of some of the ones that I've done. And this is extremely important to understand the intricate anatomical nuances of these tumors, the structures they involve, and how you need to get around them in order to not only perform the surgery safely, but ultimately get the coveted negative margin where you gave that patient the best chance at obtaining a surgical cure from their primary spine tumor disease. So let's get started with a case. This is a 35-year-old female. This was the very first en-bloc here that I did at WashU. She presented with this large left-sided biopsy-proven chondrosarcoma, high grade, involving both her sacrum, hemipelvis, and extension out into the left sciatic notch. We offer this patient, of course, a sacrectomy with left hemipelvectomy, multidisciplinary collaboration among myself and orthopedic surgery, colorectal surgery, vascular surgery, multiple people. It takes truly a village to make something like this happen for the patient. But then we're left with these large defects. And when I trained at Hopkins, conventionally we would do these Galveston techniques where we tried to bridge all the weight from the anterior column using pedicle screws and rods to the posterior column. And it wasn't really a great way to do that. And we would often find that if people did well from an oncological perspective, they would inevitably at some point fracture these constructs. And so we thought that it would be best, as we all conventionally know, if you can reconstruct the anterior column, that would be ideal. And not only reconstruct the anterior column in a way that biomechanically best bridges that anterior column weight to the posterior column of the ilium in a biomechanically advantageous way. So we're left with these defects, and we can then use that defect to plan a patient-specific implant that will fit that defect exactly. And then we can go back and execute that and implant that into the patient, and we can get that biomechanically advantageous transmission of the anterior column down to the posterior column, which is exactly what our sacrum does for us. And not only that, we can use this to not just create biomechanically advantageous constructs, but we can also maintain the patient's preoperative pelvic parameters. For those of you who've done sacrectomies, you know that when you completely disarticulate the lumbosacral junction, as you will have to do in some of these cases, you can actually put the patient's pelvic incidence in any place you want after that. But because these implants are made in a patient-specific way and we use their preoperative imaging, we can actually maintain their preoperative pelvic parameters exactly to what they were before surgery. Here's the patient after surgery. And so the first time we did that in that charcot pathology, it took us 4 weeks to plan the implant, make the implant, execute it, etc. In this case, we were able to do the surgery, leave the patient with temporary fixation, and within 120 hours, plan the implant, make the implant, get it back to St. Louis, sterilize it, and back into the patient. And this process, as I'll show you, has gotten faster. So another patient, leiomyosarcoma, completes a correctomy, right-sided hemipelvectomy. We make an implant that is able to bridge the anterior to the posterior column in a biomechanically advantageous way that we don't have anything off the shelf in order to do this. Here's what the implant looks like. And then we can do that in this case, it was within 96 hours from the execution of the surgery, getting the CT scan to define the defect, making the implant back into the patient. Now, another case here. This is a case of a large biopsy-proven C2 chordoma. It's involving C2 and C3 extension into the canal, right-sided vertebral artery. Radiation here is not a great option. It's tremendously close to the critical tracheoesophageal complex. High-dose radiation to this area is going to produce a tremendous amount of dysphagia. And so the patient elected to have an en-bloc surgery. Instead, we make the model that is, in my opinion, perhaps some of you who can translate two-dimensional MRI and CT imaging to three-dimensional pictures in your head don't need this, but I need this in order to truly understand what it is that I'm tackling. And so after the tumor is resected, and in fact, you can see the fidelity of these models to what the actual specimen looks like. You can see here the en-bloc tumor resection. C3 is hidden within the specimen. Here is the tumor. And then you can see the C2 articular surfaces in the dens completely disarticulated out of the spine. The problem is then you have no off-the-shelf implants to reconstruct the anterior column because we don't have any implants that have that Y shape that are going to take the C1 pillars down to the anterior column of the subaxial cervical spine. Now, here's another depiction of what that specimen looks like in the axial view. You can see the fidelity of the 3D model to what the actual tumor specimen looks like. You can, in fact, I think here you might actually be able to see a little bit of the vertebral artery. Yeah, right here with a little clip on it. So you can see the dens, C2 body, the C2 pedicle. Here's the spinal canal, and here's the tumor. But of course, as in the same theme as previous, we designed an implant that was able to bridge the weight of the anterior column that travels from the occipital condyle to the C1 lateral mass, traditionally down the C2 to the C2 lateral mass into the C2 pedicles, into the posterior column of the spine. And here we have to transmit those biomechanical forces from those C1 pillars down to the anterior column of C3. And this is how we do it, by making patient-specific implants. And we designed a little nook in here to put a vascularized fibula at the time of surgery. Here's what the implant execution ultimately looked like. And this patient's about 2.5 years out now, no evidence of recurrence, and he achieved a successful fusion. It's one of the last times I saw him. Because that surgery, we were implanting the patient-specific implant in native anatomical surfaces that had not been cut because they had been disarticulated at the joint. We were able to have the implant made ahead of time and executed the final reconstruction on the same day of the tumor resection. So now let's shift gears a little bit. Primary spine tumors, there's a great debate. This has been going on ever since I was a freaking medical student at Hopkins. There was always two schools of thought: go en-bloc versus intralesional. And, you know, for the lack of a better analogy, if you got unwanted plant and weeds growing in the ground, en-bloc is, of course, taking out the whole plant and the weeds in the soil around it. And intralesional is taking everything out, little bits and pieces, and leaving maybe some weeds and roots in the ground and hoping that the weed killer is going to get that after you're done. And of course, like anything else in our literature, someone can write something in support of what they believe if they do the appropriate statistical analysis that fits the pre-existing narrative that they believe in. And so you're going to find multiple series that separation surgery and high dose radiation has comparable rates to the best en-bloc series. But you're also going to find a multitude of papers that show that en-bloc surgery offers patients the highest likelihood of progression-free survival and long-term survival. And one of the ways that I look at this is that when you normalize the people who undergo radiation to the median, to the mean in a normal curve versus the people who undergo an en-bloc surgery, some of those means are going to look quite similar. But when you look at people who are outside the mean, right, so they're in the tail ends of the confidence intervals, there is essentially no cures, very few cures of the people who undergo radiation. They might have had similar, as a population level, control rates and progression-free survival, but there's going to be few people who experience cures. The en-bloc population, in contrast, will have a multitude of people who did experience those cures, and that is ultimately what is being offered to these patients, the chance at being in that tail end of that curve where they experience the curve or a cure. And if you talk to oncologists, that's essentially where they live as well. That's why they're eternal optimists, because they're trying to get people to be in the outside of the curves, not in the median of the curves. But ultimately, even Dr. Bilski, who I know speaks in favor of separation surgery and high dose radiation, even he has wrote multiple authored papers where he acknowledges that when feasible and associated with acceptable morbidity, en-bloc resection can offer superior disease control. But the devil's in the details, because when is it feasible and acceptable? And we don't really have a great way to define that, because it's not a black or white, where if you train to do en-blocs, you do en-blocs, and if you train to do separation and radiation, you do that. It shouldn't be like that. We should have a more nuanced and objective way of studying this to determine whether a surgery truly has a feasible and acceptable morbidity to be offered an en-bloc resection. And if the answer to that is no, they should be offered a separation surgery with radiation. And so I really internalize that, and I've put some thought and effort into trying to define this, because en-bloc resections really truly are challenging. Without question, they have high morbidity, long operative times. They require a tremendous amount of planning, not just from the surgical team, but the perioperative team, long hospital stays. They mandate a tremendous amount of resource commitment from basically everybody in the hospital. And thus, we have to be really thoughtful about offering these surgeries to people and when they make sense. So we came up with this framework. This was recently published in neurosurgery, called CLIMR. It's divided into 4 main pieces: column, line of sight, margins, and rings. And I'll briefly go through it in the setting of this patient vignette here. So this is I believe, 36-year-old male, Jehovah's Witness, who presented with this biopsy-proven L2, L3 chordoma extending into the spinal canal, as well as his left psoas muscle. Highly educated, got multiple opinions. In the era of LLMs and generative AI, he spent a tremendous amount of time researching what he thought would be the best option for him, and based on his and other opinions of the data, he ultimately decided on an en-bloc resection. But then he had a hard time finding people to offer him the en-bloc resection, because he still would not accept blood. I took the case upon with him. We made the model. Here's the model. It allowed me to understand the proximity of the tumor to the vessels as well as the vertebra, because the entire vertebra, of course, have to come out. And we were able to design a plan. So we look at the first part of the column. This classification system breaks this down, the column part, into what type of cuts you need to make into the anterior and middle column of the thoracolumbar and cervical spine to separate it from the rest of the spine. And those cuts are made depending on where the tumor is invading that aspect of the spine, and if you look at this figure progressing from A to E, the complexity and morbidity of those cuts increases, and they are assigned a higher score, so that ultimately, when added to the remainder of the scores, a higher score is going to denote a higher complexity, and as you will see, associated morbidity to the case. So all the way from A, which is a sagittal split osteotomy, which is a relatively simple osteotomy, to E, which is a two radical discectomies. And if you've done these procedures, you know that cutting the entire disc out so that it is completely, so the vertebra in between those discs is completely free and mobile, is actually highly complex and sometimes risky versus cutting through bone, which is quite familiar and less technically demanding for us. Now, line of sight has to do with what type of access do we need to have appropriate visualization and control of the difficult and critical parts of the case. So in this case, while this procedure could likely be done in a posterior-only approach with an acceptable level of risk in a person who accepted blood, for this gentleman, that was not an acceptable risk. So I performed a direct lateral retroperitoneal approach, found all of the segmental arteries and veins within L1 to L4, ligated them, was able to then place in blue is a delineation, and we place a silastic sheath, which essentially maintains an anatomical plane safe and away from you when you perform your posterior approach. And that completely de-risked this procedure, because now that the major visceral and vascular structures are protected and out of the way, we then went from the back and made all of our appropriate cuts. For the purposes of the scoring system, each additional approach that you need to do adds an additional weighted score that will increase the morbidity of the procedure. And so in this case that I showed you guys earlier of that high cervical chordoma, we needed to do a submucosal mandibular split. It's not the conventional, transmandibular approach where the patient looks like a character from the movie Alien, but rather a submucosal one where you put wires into the mandible and you spread the wires when you need high access, and then you let them relax, and it's a dynamic retraction. It's a little bit less morbid, but nonetheless, it adds an extra layer of complexity to the case that mandates that higher score. Margins, that component of the score really talks about not the needing, we all know we need to get negative margins, but what do you need to sacrifice to get negative margins? And with each additional structure, from things that you can sacrifice with minimal morbidity to things that, for example, limb sacrifice in a hemicorporectomy, that is the most morbid thing you can do to a human, the level of the score progressively goes up, given that procedure a higher morbidity grade. And so, for example, in this case, this gentleman who had this large sacral chordoma extending into his abdominal and pelvic cavity, he had to have part of his colon resected as it was invading the mesorectum. And that is going to be life-altering, and it's going to require changes to his quality of life. And we need to acknowledge that and study that. And of course, here's the patient. Now, last but not least is ring, the last part of the classification system. So the ring talks about where you need to open the vertebral ring in order to safely deliver the neural elements as you're rotating that vertebra out of the field, out of the patient, the vertebra that contains a tumor. And of course, the bigger the window that you can make, the less neurologically risky that maneuver is. So if you can do a conventional complete laminectomy, as in A here, without getting into the tumor, that means that the entire posterior elements can essentially be removed. It's, of course, still somewhat technically challenging, but neurologically much safer than if you have near 360-degree involvement of the vertebra, and all you can do is make a small pedicular window on the side and have to deliver the spinal cord or thecal sac out that small pedicular window. And so the neurological risk and complexity of that progressively goes up, giving it a higher score and a higher potential morbidity. So, for example, this radiation-induced sarcoma, you can see it had near 360-degree involvements of the vertebral body among multiple levels. And all we could really do in the posterior elements to open up the ring was make multiple pediculectomies and deliver the spinal cord through those pediculectomies. You can see here 3-level spondylectomy in the mid-thoracic spine. The spinal cord was delivered through those small multi-level pedicular windows combined with nerve root ligations. This is a tumor specimen. So you put it all together and you come up with a different score for each component of the procedure, and then we can study that and see if those scores really truly equate to higher morbidities. And eventually, I'm hopeful that this will allow us to get to the point where we say something is too morbid for an en-bloc. Here is the specimen from that L2, L3 en-bloc spondylectomy for our Jehovah's Witness patient. Here's what it looked like, the reconstruction after we were finished. This is one of the last times I saw him. So here's another example. This is a left-sided multi-level cervical thoracic MPNST resection. Patient's mother had actually been also in the care of our NF1 center, and she had died from an MPNST, so we were very aggressive with treating this at the request of her oncologist. Here's the model. Here's what we ultimately planned: the sagittal split osteotomy with multi-level approach, posterior and anterior. We did a special osteotomy to get access to the upper thoracic spine that was behind the clavicle and the manubrium. Had to sacrifice muscle, pleura, subclavian artery, subclavian vein that were bypassed, some eloquent nerves that were involved with the brachial plexus. But thankfully, the ring was not too complex, as we could completely skeletonize her spinal cord and nerves from the back without getting into the tumor. And so in here, that special osteotomy, we simply used our ultrasonic bone scalpel to remove the manubrium and the clavicle, pre-plated. Once you remove that, you get access to the upper thoracic spine, as well as the anterolateral space to get that tumor out. Here's the tumor.
Is there sound with that, Camilo?
What's that? Oh, was there?
Was there
You
was
guys
there
couldn't hear
sound
the
with that?
sound? Yeah, you guys
No.
couldn't hear the sound. I'm sorry. We'll get right through that. Here's the specimen. I apologize.
You're
And
all
then
good.
here is
You
what
were delicately fondling that tumor.
that's funny. I was explaining what the cuts look like, and then of course, once the clavicle has been replated. So in that paper, you'll find the results if you're interested. But as expected, as the score went up, the morbidity of the cases did go up. Length of stay, blood loss, transfusions, infections, all the things that we care about. And now we're looking to validate this in a multi-institutional fashion. And like I said, really the end result here is hopeful that we can define the gray zone that exists where some surgeries have an acceptable level in feasibility of execution and morbidity to be offered an en-bloc, and some simply we say it's too much. One thing that often comes up is, what about patients who present with acute evolving neurological deficits? I think that if you have the training and capability to do this and the patient is young enough and robust enough, I still think they should be offered the en-bloc surgery. This was a 31-year-old gentleman, big guy, had this known biopsy-proven osteosarcoma that we were actually in the middle of planning an en-bloc resection, and he spun out of nowhere, showed up to the hospital, bilateral lower extremity strength 0 out of 5. It was 4 or 5 p.m. at night. The tendency is to say, oh, God, I can't believe I'm going to start an en-bloc this late. Let's just separate it, radiate it. But that's not the right thing to do. So, took him at late at night and did the en-bloc tumor resection just as I would have in any other patient. And he was able to regain his neurological function. This was one of the last exams that we had here in the hospital before we left. You can see he was essentially 4 out of 5 to 5 out of 5 in all of his major muscle groups. And one of the last times that I saw him in clinic, he was essentially back to full strength. So these surgeries, they can also be done in an urgent emergent fashion, and you can still achieve the desired neurological outcomes. And it's a misconception that because there's an evolving neurological deficit, that you have to go in guns blazing and completely throw out all the oncological principles out the window. So I put this case here.
Clinic the next day, however, will be brutal.
Clinic the next day was not my favorite, but I also hate clinic in general. But I put this case on. I just did this case about 2 weeks ago. I put it on for Greg because some of these patients have both of the problems that we care about. 70-year-old woman, very healthy farmer. You would think that she was 45 years old in terms of her other medical comorbidities, really no concomitant medical comorbidities, with this large L1 to L3 spanning biopsy-proven chordoma. And she also happened to have a horrendous sagittal plane deformity. Shopped this case around with a couple of colleagues. Of course, oncology colleagues said, en-bloc it if you can. Deformity people said, well, you have to correct the deformity as well. But some of the oncology people say, well, that's too much. You can't do both at once. And if you understand both these patients' populations, you know that people with this horrendous of a sagittal plane deformity, their ODIs are comparable to people with chronic cancer. And this lady has both. So if I really, truly in my heart believed that I was going to improve the survival of this person by doing an en-bloc tumor resection, I couldn't leave her with this disabling sagittal plane deformity. So, of course, as described above, we did the en-bloc tumor resection. Here's the pathology report, achieved negative margins. We use, in this case, not patient-specific inner bodies or corpectomy cages to execute the surgery, but patient-specific rods to realign the patient. We made our pre and post-operative realignment plan, got a patient-specific rod, and we're able to successfully realign the patient after doing the en-bloc tumor resection by correcting the lumbosacral realignment and using the corpectomies from the en-bloc tumor resection to correct the thoracolumbar alignment as well. That is all I have for you guys. Hopefully a little bit of food for thought, and I can't complete this talk without giving thanks to all of the people who I work with who make this work possible.
Thanks, Camilo. Really impressive, man.
Yeah, the fellas were just like, their jaws are all dropped at the table. The reality is, like, there's only so many of you out there, right? There's not that many Camilos that can handle, and I would say I would probably broaden that too, right? Because you understand it's a health system too and team that can handle these kind of types of cases, right? So there's, I don't know, how many centers do you think do this well?
Maybe 10.
Right. So, when we see these patients on call or et cetera, like, for practicality's sake, what should we be doing? Like, should we be referring all these patients to one of these 10 centers? Or is that where the place for separation surgery may have its place, because the specialty as a whole, spine surgeons, we may not have the capacity to manage the volume of patients, or the patients may not be able to travel and may not be able to, make that sacrifice. Like, what's the right answer for those people that can't have the ideal? Is it all or nothing, or
I would say that if a patient shows up and they have a rapidly evolving neurological deficit within hours, or maybe just a few days, 72 hours, and you absolutely say there's no way that I can offer an en-bloc tumor resection. That's not out. It would be unsafe. It would put this in the, unacceptable morbidity range. I 100% decompress the patient, get the, protect their neurological function, plan for separation surgery, radiation. We know that has acceptable levels of control and outcomes. We know that I don't think that there's any problem with doing that. I think if you encounter a patient who maybe they have a, I don't know, 4 out of 5 quad weakness, like some of these patients often do on the side where the tumor is, but it's been stable for weeks to months, and you have a concerning tumor, they have no other disease, and it's in their spine, biopsy that tumor. If it's a primary spine tumor, and you don't take on the case if you're not prepared for it and you're not an expert at that. Send it somewhere and let someone have the equipoise to decide whether an en-bloc tumor resection or separation surgery makes sense.
Okay.
I mean, even the biopsy is a problem in a lot of places. Like the performance of the biopsy is subject to error.
Yeah.
Yeah, I don't disagree. I recently did a case where somebody did a biopsy and they went through and through the tumor capsule. You can see it on the CT guided biopsy, and so of course the margins are going to be negative on or positive on that. And so you're right. And if you're in a facility where you don't even trust that they'll do the biopsy appropriately, but you're suspecting that it's a primary tumor and there's nothing that's rapidly evolving, get that patient somewhere where somebody can. I mean, I think that most places are going to be within the vicinity of a center that can handle this.
Yeah. Cool. Are you using Degen Medical
For the corpectomies, for the
Yeah.
patient-specific corpectomies? I am, yeah.
Oh, okay.
Where do you get your 3D models made?
Here in the hospital.
Oh, they offer it. Okay.
We have a 3D printing lab here.
They have a whole system there.
Yeah.
Yeah.
So like once you realize like the intricacies of
Yeah.
these centers, like it's different.
When you first started there, was this infrastructure in place, or did you have to kind of, put some legwork into getting everything kind of set up for you?
We've put in a lot of legwork to set it up. We did not have a robust spinal oncology center. Myself and a colleague, Dr. Matt Goodwin, have put a lot of thought and effort into this, and now it's fairly streamlined and robust.
Awesome.
If you could have the
one-
SPD, they'll print one of those for you.
I'm sorry, say that again?
Oh, I just said if oh, never mind. I'll tell Johnny offline.
Okay.
Yeah. So one more thing. These are obviously massive cases. What's like the, wound complication, infection burden, and then how you guys kind of mitigate that? Because like I see these big whacks and I'm thinking, it looks awesome, but just practically speaking, like what kind of challenges are you navigating from an infection standpoint? And like, what are you using are you sending these patients home with oral antibiotics, or are you taking any extra measures?
The wound complication rate is high. I think the last time we looked at it, it was like 25%. It's pretty high. And I include in that anybody who has some persistent like wound drainage that maybe don't require a take back, but we're dealing with a wound vac, or maybe having to replace a percutaneous drain for a seroma, something like that. It's not small. We work with plastics quite often. The vast majority of these cases, the goal is to do some type of rotational muscle flap, and sometimes we've even had to do free flaps to close the dead space. That's absolutely critical in these cases, because if you have a huge dead space in there, it can only fill with seromatous fluid, and any small amount of bacteria that gets into the patient's bloodstream from any other reason, whether it's a UTI or a little bacteria that got in there from a central line or whatever, it finds its way into that seroma, and that is like a petri dish for infection. So closing down that dead space and leaving the drains in for a tremendously long period of time until they're quite low output is absolutely key.
Yeah. Do you guys do all these operations in one? I mean, obviously, when you have to send out for the implants, it's on 2 separate days. But how many surgeries are like done on single stage, beginning to end, with all the different specialties involved?
I would say the front backs, with the exception of the cervicals, are done on different days. The cervicals, front backs, or back front, or whatever you need to do, those I'll do on the same day. When there is a implant that is involved, then there's going to be 3 trips to the surgery if we can't do the implant ahead of time because of the complexity of the cuts. So that will be a 1 or 2 stage approach for the original tumor resection, and then another return 48 to 72 hours later for the implant.
Okay.
And you should do that return relatively soon because those structures will scar down pretty surprisingly fast, where it will be very difficult to get those large implants in to fit as nicely as you design them.
Yeah. Awesome.
Thanks for a bunch, Camilo.
Fantastic.
Thanks, guys.
Yeah. Have a great day. Have an awesome week. We'll talk soon.
All right, guys. Take care. Bye.